So good morning, everyone, and thanks for inviting me and asking me to chair this session. In fact, we're going to talk about newborns, and particularly those newborns that are at particularly high risk, the premature newborns and low birth weight newborns, very often a group that is mixed. And as we have heard in the last few days, newborn mortality, unfortunately, has not dropped as significantly as under 5 mortality, and so proportionally it is, in fact, rising in the under 5 mortality group. The good news, however, is that we have also heard in the last few hours there's quite a lot of things that can be done without very high-tech interventions. So what we're going to focus on, and what we have focused on in the last few hours, is some of the experiences in MSF contexts and what has been achieved. And in the next couple of presentations, we are going to have, it's going to be a little bit different from what you see in your schedule here. First, Mats is going to talk to us about the importance of oxygen and/or air pressure. And Mats, I have to thank you first of all, because Mats was the one who helped us introduce CPAP in one of our projects in Jordan, and it is the first project in MSF OCP that introduced CPAP in newborn care. So thanks a lot, and I'm very honored to sit next to you here. And after that, we are going to hear a presentation on kangaroo mother care, or I've always said KMC is something that is promoted by WHO as if it was something very easy. It might be cheap, but it's not easy. And as we've heard, it's possible, but it does need quite a lot of effort, determination, and I'm very much looking forward to the presentation that we're going to hear from Cape Town, which is, of course, in Africa, but is not necessarily the kind of context that we are used to work in. So, one more thing that I wanted to say is that I'm very happy that we're talking about newborn care here, because newborns in MSF were a non-existent population until not very long ago. They did not exist. In fact, they did exist, but they did not exist in our minds. And since we have started acknowledging them, our programs are almost overrun by newborns. And the big issue and challenge we have is to find context-adapted solutions, which means the solutions in Jordan will not be the same as in South Sudan necessarily, and we have to learn and exchange in order to find the best adapted solutions to help not only save the lives of the majority of those children that come to us, but also allow them to have a good life after they have been discharged. So without further ado, Mats.
Okay.
Thank you very much.
So it's a very
and
great...
you have 25 minutes as far as I've...
20 or 25?
Yeah, 20 minutes.
I tried to stick to 20. Okay, it's a very big honor for me, being a rookie in this organization, to be able to address you all and talk about one of my favorite topics, which is how to support babies non-invasively using CPAP. This baby is actually not number 1 in IRBID, it's number 3 that were treated by nasal CPAP in the project, and it was very much embraced by all the nurses and the fabulous national nurses and fabulous national pediatricians I had the honor to work together with there. How do I swap? Not? Okay, there. So it's important to look at history. This is from US, where Alan Jobe, a couple of years ago, Alan Jobe is a icon in international neonatology. He tried to look at what happened during the 20th century in the United States and what had the biggest impact on the increasing survival of infants with low birth weights. And what they came up to, scrutinizing all the literature out there, was that the introduction in the 1940s of oxygen helped to save something like 20% of those babies, more than 1,500 grams, presenting with respiratory distress syndrome. The big leap came with the introduction of CPAP. That increased the number of babies that survived with something like 50%. On top of that, we have modern Western neonatology, introduction of surfactants in the late 1980s, Ventilator care starting in the 70s, dedicated ventilators from 85, 86 something, and further on with more advanced techniques, but also with improvements in nursing care. I would like to start by saying, pushing this fact to you, that most babies do breathe when they're born, even the very low birth weight and extremely low birth weight babies. This was shown very nicely by Colm McDonald and Colin Morley in Melbourne a few years ago when they looked at newborn babies, and even those ELGA babies, less than 26 weeks of gestation, 2 out of 3 of them did breathe when they were born spontaneously. So actually, the vast majority of babies do not need positive pressure ventilation for not breathing. We're not resuscitating them, we're stabilizing them. That led to the concept of doing a soft landing of the babies, not doing more than they need, not giving them more help than they need. Ooh. Oh, what's this?
Excusez-moi. Bon.
Hello.
Yeah. Mesdames et messieurs, mina damer och herrar, ladies egentligen. Yes. I'm going to present to you the greatest, most magnificent, talented Dr. Perm Fritz. His abstract is going to be about brain surgery. So it's the latest things in brain surgery. So you're lucky to be here. Are you ready, yes. Dr. Perm Fritz? Yes. All right. Okay. Okay, sorry. Are you sure?
Yes.
Can't we take another one?
Yes, this is the first time I perform with this experiment. But, we do it on a clown head today. If you don't understand what I say, you can ask your neighbor to transpiration, because my English is not so good. Yes.
Oj, 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 oj,
Yes, this is, we do it not on the children, but on the clown. Yes, it's a sad clown, but then after, she is very happy, I hope. Okay. Yes, I take this one here. Okay. I'm a little bit nervous now. Okay. Huh?
Works good.
Yes. It feels good?
Yes.
Very good, very good.
I feel great.
Yes. Then we will entertain the children now.
Yeah.
Yes, goodbye.
And are they allowed to use this method?
No, it's me, it's mine.
Okay. Okay, sorry. Dr. Prof.
Oh, they forgot this.
Oh, they forgot their hat.
Dr. Pam, Fritz, and Milda Matilda. They are from... Milda Matilda. You are from...
Yes. Ja, varsågod.
You are from Glädjeverkstan here in Stockholm. Yes. You are hospital clowns, yes, which we have also in Gothenburg. I know you are. I know you had a. Did you have a clown forensic recently?
We are going to have a clown conference.
Wow.
Yes, in 2 weeks'
All
time.
the Swedish hospital clowns.
Together.
You are vital, extremely important for the children in the hospitals of Sweden. And we thank you very much. You meet 25,000 children every year.
Yes,
is that true?
Yes, it's true.
Incredible.
Actually.
Thank you very much.
And thank you for letting us be here.
Yes. Good luck.
And please continue.
So, do you think I can manage this after that? That was great. Okay, they do breathe when they're born, even if they had brain surgery. So, but the population that we are more interested in, they breathe in even higher numbers, so up to 86% of the babies between 28 and 36 weeks do breathe when they're born. But they do need support. And these two movies show you what it looks like in a newborn lung if it's started breathing without having positive pressure and expiratory pressure. That is on the left, and on the right there is a lung that is supported by positive airway pressure, CPAP, or PEEP. And what you can see is that in the non-supported lung, only the proximal airways open up for every breath, and there is no build-up of a functional residual capacity. The babies are born with liquid-filled lungs, and they have a very bad compliance, so we need to support them in one way or another. These are studies done by Stuart Hooper in Monash, Melbourne, Australia, and they are very, very easy to understand the need for positive airway pressure in the newborn baby. So CPAP, what is that? It's also called the continuous distending airway pressure. It has a lot of very good effects for the newborn baby. It reduces the pharyngeal airway resistance and thereby alleviating and helping the babies not to having obstructive apneas. It, as we saw, increases the functional residual capacity of the lung of the baby, and it splints also not only the upper but also the lower airways, as we saw, when it creates the functional residual capacity. And by opening the lung, we also reduce the pulmonary artery pressure and the lung pressure so that it decreases the right to the left shunt. It also, you have to press. It increases, that's the full meaning of it, the mean airway pressure, helping the baby to oxygenate the blood. It preserves surfactant, and it reduces the tendency of the newborn lung to develop an alveolar edema. Especially in the stiff lung, in the newborn lung, it increases the compliance of the lung, and it by doing all these beautiful things, it reduces the need for tachypnea and reduces the respiratory rate. By stimulating pharyngeal receptors, it's also effective in reducing central apneas because we do have sensors for breathing, and if the brainstem doesn't work properly, CPAP helps with that. As we heard this morning, CPAP was introduced in the late 1960s. Usually everyone refers to the Gregory Box. That's the device to the left here. A variation of that is shown on the right. That was used by Nils Svenningsson, who is one of the real ancestors of CPAP care here in Scandinavia. Both these utilized an increased pressure in the room around the baby's head, and it had a very tight neck seal. It was very successful in reducing mortality in the babies, but unfortunately, due to the venous congestions, quite a few of these babies did develop venous hemorrhages in the brain, subependymal interventricular hemorrhages, and it became sort of out of fashion. Some enclaves of the world, like here in Scandinavia, we retained to use CPAP for primary support of babies. Also, Dr. Wung in New York was a very good promoter of using CPAP. Today, we do have new devices to administer CPAP. We heard of one budget one this morning that was very interesting to hear about. The quickest way to administer CPAP to newborn babies is by using the TPIS ventilator that we are equipping some of the units out there in the low resource settings with now, and they are very frequent in the Western world. It's the NeoPuff is one of the brands, and as soon as you put the mask over the face of the baby, you have a CPAP pressure. There's a lot of talk about bubble CPAP or other devices. Bubble CPAP is one way of providing increased pressure to the lungs of the babies, usually done by using these Hudson prongs. And there are an increasing number of abstracts and papers published on that. The other main route to give a positive airway pressure is to use a variable flow CPAP, initially invented by Dr. Moa up in Östersund in northern Sweden. That's the infant flow, where you use a high flow that flip-flops during inspiration or expiration, thereby said to decrease the work of breathing of the baby. And also, this is one of the pictures from the project in Irbit. So you are able to combine the two. The talk we will hear by Nils later on with both skin to skin, or as here, kangaroo mother care with some dressing in between them, also in Muslim countries and in different settings in the low resource settings. The device to give provide CPAP in low resource settings. We heard one very interesting variant of that this morning. There are quite a few examples of that. Basically, for the bubble CPAP, you need something to give you compressed oxygen and another device to give you compressed air. And then you need to mix the two and have an algorithm or a measurement to see to that what concentration of inspired oxygen the baby gets. You need to attach it by some means to the baby's nose or to the baby's airways. And then you need to create a pressure by on the exhaustive part of the system, having a bubble flask with a bubble where you can set a meter on the centimeters of pressures you want the baby to have. It's important to have this one on the expiratory limb and not on the inspiratory limb, not to create an increase in the dead space of the baby. We also heard about this, the America CPAP, which is a development of the oxygen concentrator, working as a bubble CPAP and with a passive humidification of the breathing gases for the baby. Sometimes when you get out there and discuss CPAP, you are approached with discussions on what pressures to use. There are no universal guidelines for this, actually. You need to know your system, really, because there is inborn performances of different devices, and the recommendations of what pressures to use vary quite widely. One of the bigger trials, the COIN trial, said that you always start at 8 centimeters CPAP, and then you wean it later. We usually go for 5 to 6 centimeters of CPAP, and I would say that this depends on what different systems you use and what interface you have for the babies. If you look at another work by Colin Morley, published quite a few years ago, this is a bench study where they looked at just the interface between the baby and the device. It's clearly seen that if you use a single nasal prong, you lose something to up to 4 to 5 to 6 centimeters of water pressure just over the device, while using the Hudson prongs of a medium size or the infant flow prongs, you do not lose any pressure whatsoever. They perform equally, but you need to know your system. This is perhaps the most important slide today of all, and that is that there is no CPAP program that works if you do not have good nursing. You need to have very clever nurses that knows how to adapt the CPAP to the babies and adjust the CPAP and help the babies in a comfortable position to be able to breathe. Infants breathe on their nasal passages, therefore you need to keep their nasal passages open. We do refrain from suctioning the nose because that only causes mucosal damages. Instead, we drip saline into the nose and suction the oropharynx to keep them open. Also, very important is, and that was my question to the previous speaker, about humidification, because we are discussing high flows here, up to 8 to 10 to 12 liters per minute, and that will dry out the nasal mucosa if we do not humidify the breathing gases properly. Also, there are a lot of small tricks. Use a pacifier to close the mouth, for example. And also this, that the NICU should be designed to accommodate for parents, to be there for the babies, and also for having a comfortable and neurodevelopmentally correct position of the baby. This upper photograph here is also from the MSF project in Irbid, where they rapidly caught up on CPAP treatment and also on kangaroo mother care. And the mothers came there, they sustained the babies, they helped them, and it was a very good success, and it's, I think, still sustainable. Anas is somewhere here, one of the clever pediatricians, I think. And he told me the other day that up there he is, together with 3 colleagues and 10 nurses, did this possible. Swapping then to oxygen in neonatology, it's important to state that oxygen saves lives. It's the most powerful relaxator of pulmonary arteries, much more so than nitric oxide, actually. So the thing is to oxygenate the baby, but just about enough. We have a word in Swedish called lagom. That's just about enough. It's not too much, not too little. Oxygen is also necessary for growth, and it is supposed to protect neurons. We should keep in mind that the baby has a hemoglobin, fetal hemoglobin, and the fetus is adapted to a PaO2 corresponding to what people experience when they climb Mount Everest without supplemental oxygen. This was stated as the fetus on the top of Mount Everest by Sir Barcroft in the early 1920s. For preterm infants, oxygen can be administered by free flow, by mask in front of the mouth. It's quickly diluted, and it's a very insecure way of giving a set FiO2. It's also administered by free flow in an incubator. But most units nowadays use nasal cannula, either using a low flow setting up to half a liter, sometimes up to 1 liter, or what has become very, very popular over the last 5-6 years has been high flow nasal cannula oxygen, or HHHFNC, heated humidified high flow nasal cannula oxygen. Whenever giving oxygen to a preterm baby, always monitor SATO2 saturations. That cannot be enough stressed. And also I would go for it, the breathing gases should be heated and humidified. I'm sorry to say that I do not agree that you can humidify by bubbling the gases through cold water. It doesn't contain any humidity excessive of what you have already in the room. When it reaches the baby's lungs, at least. And the reason I stress this is that we think that retrolental fibrillation, or ROP, retinopathy of prematurity, is something that only goes in the Western world with 23 to 24 weekers. It's not. This gentleman here, Stevie Wonder, the best musician ever in my account, he was born in week 33 in the US in 1949. And the reason for him being blind is that he was giving ad-lib oxygen during his NICU stay. So it is a reality, and this is a worry for when oxygen become available in low-resource setting, where the respect for these consequences following oxygen is not the same as here. To heat and humidify the breathing gases is very, very important, especially when you go to higher flows. It's critical because unhumidified air, dries out the mucosa, it kills the cells, it increases the risk for nosocomial infections, and it also creates a thermal loss, which is an energy loss to the baby. Lastly, just a few slides. Do I have 2 minutes?
You have 3.5 minutes.
3.5? Oh, my God. This is just illustrating what I just said about high-flow nasal cannula oxygen. These are the numbers of publications up to 2013 in PubMed on high-flow nasal cannula in neonatology, and it has really exploded, especially since the Australian publication where they used high-flow nasal cannula for babies being extubated as the primary support after mechanical ventilation, and showing that it was non-inferior to CPAP treatment after extubation. This was a non-inferiority trial. It just reached statistical significance. It was 18% less good than CPAP after extubation. They had set the criteria to be 20%. And also the babies on high-flow nasal cannula could be salvaged by CPAP. It's still out there. The question is still open whether it's as good, but it is a very good way of supporting newborn babies, especially if you do not have access to proper electricity and combination of fractionizing oxygen. The hypothesis between a high-flow nasal cannula is that it use a constant gas flow. Usually it's said to be kilogram body weight plus 2 liters per minute, and that this constant high flow creates a positive distending pressure. So it's a variation of giving CPAP, but it's uncontrolled. There is a blow-off valve in the commercially available systems at 35 centimeters of water. The worry about the air leaks, pneumothoraces, should be there for HFNC just as well as it is for CPAP. And the level of this distending pressure, the CPAP pressure that it produces, is depending on the size of the baby, the flow of the gases, and the cannula size and everything. So you do not actually know what you do. But usually in the studies that have been done, you can measure pressures up to 4 to 5 centimeters if you have flows up to 6 or 7 centimeters, but it's very variable. The proposed advantages of using high-flow nasal cannula is that they are heated and humidified, the gases, avoiding the problems with the mucosa I talked about. It also, if you have these flow, it covers the minute ventilation of the babies, so you do get the FiO2 you set to give the baby. With low flows, with half a liter or 0.25 liters, there's a rapid dilution, so you need to be aware that you need to go up quite high in oxygen FiO2s to get the alveolar FiO2 you are aiming for. It's also supposed that the flow of oxygen also supports the breathing efforts of the baby. And in contrast to when you treat a baby with CPAP, when you want the mouth closed, when you treat them with high-flow nasal cannula, there's no need for that. It's even recommended that the babies keep their mouth open because the constant flow of gases wash out the dead space from carbon dioxide. thereby reducing the PCO2 of the babies, which is a major problem in the later period. So I'd like to sum up just saying that CPAP is the primary ventilatory support that should be used to support newborn infants. Even very low birth weight and extremely low birth weight infants nowadays in the ILCO recommendation should be given a try of CPAP. There's no need to intubate them to give surfactant immediately any longer, but early rescue is what is recommended in that case. That is a bit outside the scope of this Congress, but it's good to know. No CPAP system has hitherto been proven to, with equal competency, give better results than the other CPAP system. There have been discussions that bubble CPAP creates oscillatory movements corresponding to high-frequency oscillatory ventilation. That's probably not the case, but it's still cited widely. Short binasal prongs are the best interface with the machine and the baby. And if you use higher flows, as in all CPAP systems, but also with high-flow nasal cannula, the breathing gases should be humidified and heated. And the saturation must be monitored when you treat a newborn preterm baby with oxygen. I might have sounded critical towards high-flow nasal cannula, but I think it's a really good method, and I think the use of high-flow nasal cannula within the MSF settings will increase incredibly over the coming 3 to 4 years. So I'd like to stop there, and thank you all for listening to me, and I'm happy to take questions.
So thank you very much. That was very comprehensive. And I think we will have 3 questions now. Then we'll have Niels's presentation, and then we will have enough time for questions for both presentations. So are there any burning questions right now at this point for Mats? Yes, I see. No, you have to wait for the microphone. As much as we're time constrained, there is still...
So thank you very much, Mats. Zulfi Butta here. That's fascinating as a summary. I wanted to ask you what your opinion is on the use of these high-flow or low-flow systems, be that as it may be, to look at treatment of babies, young infants, in the interface between the newborn period and the first 3 months of life. So if you take the spectrum of respiratory disorders that we have in very young infants, especially with the results from Bangladesh of the treatment of severe pneumonia with nasal flow systems, is it possible in low-income settings to have a common apparatus that can be used both for newborns and young infants using this principle?
I would guess so, really. I mean, the Preterm, for example, which is one of the commercially available high-flow nasal cannula systems, are used both for preterms, newborns, toddlers, and the bigger babies up to, I think it can go up to 12 liters per minute, something, and that would accommodate the majority of children under 5 years of age to be used. I don't know whether that was your question, really, or... No, but it's definitely possible. We interchange apparatus between our pediatric ward and our NICU sometimes, and it's the same setting. We have a homemade system for high-flow nasal cannula, which we use here at Karolinska, at least in one of the settings. And that one works just as well with the larger babies, the newborns or toddlers.
Thank you, David.
Could I ask what levels of oxygen saturation you are saying is needed to be kept to or below for safety in these settings?
Well, Safe Boost, which is a very big trial, run in the United States and in Australia, and then we had the COT trial in Canada, and they came out with quite a few meta-analyses on the results there, where they randomized babies to high settings, which was 92 to 95, or low settings, which were 88 to 90 in saturations. And They wanted to show that it was safe with 88 to 90, but actually mortality increased. So there has been a large debate. I think most of you have heard about it. So now the vast majority of units, at least our units in Sweden, go for 90 to 95. Probably, we have seen an increase in the frequency of ROP following this. So that is something that we need to be aware of. And people that are in the ROP field are discussing whether to use these saturation limits of 90 to 95 during the first couple of weeks in the very low birth weight babies, and then go for 92 to 96.
Certainly that's the normal range. If you monitor large numbers of preterm and full-term babies over 24-hour recordings, that's exactly right.
Yes.
So thanks.
But before these trials, Safe Boost, some units here in Europe had 80 to 85.
No, I agree.